Our next speaker is Dr. Tito Fojo, and he will be talking about real worth of high-priced drugs.
So actually, David and I were talking yesterday, and I said, if we vote at the beginning, you'll see that I got the easy one, and you got the hard one. I thought there would have been a few more votes. I think I saw 3 hands raised, and they were probably feeling bad and just decided that they would raise their hands. So it's really not a fair debate, but it's to give you food for thought, shall we say. So obviously, I got the easy one, because you get to speak from the heart, if you will. So I did have to, I'm not like David, so I had to look up what commodity was, and this is a definition that you find for commodity. And so what caught me here was raw material, can be bought unsought, a useful or valuable thing. Now, I thought that I would become a commodity if we thought of healthcare as a commodity. And the thought that I was raw material, bought and sold, or a thing, that for me was a non-starter. So there was no way I was going to agree that this was a commodity. So healthcare is a basic human need or right. I think really everybody agrees with that. And as I will argue, it is important, very important, that we see it as a basic human right or we will fail in our mission. We actually have a mission, and especially those of us here have a special mission. So it's been talked about. President Obama signed the Affordable Care Act, which is the Patient Protection and Affordable Care Act. And actually, it viewed healthcare both as a right and as a commodity. And so it was sort of undecided as to what it would be and felt that it should be both. Now, it's a human right that operates outside market forces. I think that it's a human right that requires government supervision to function effectively, and the supervision is the key here, I think. So that it requires government supervision, I think, is not in question. For example, in the United States, even if we ignore Medicare and Medicaid as examples of government supervision, and see them instead as, in the case of Medicare, something you've earned by contributing all your life to it, and Medicaid is something that you need, although you may have earned it as well, we still have things such as the Food and Drug Administration, which is a clear example of government supervision. So the Food and Drug Administration makes sure that we don't get something approved that should not be approved, and they do that reasonably well. Now, we must not view it as a commodity, I think, because we may then sit back and assume government will take care of everything, and government can't take care of everything. I think we know that, and in some countries that's more obvious than in others. And in fact, it shouldn't, because in many cases it doesn't do this as well as it should, and the idea that government can do things best is actually not one that's supported by the data. In the U.S., I think there's likely a consensus that crosses political lines that feels strongly that patients, or consumers, should be free to make decisions regarding their health care, and those who live in the United States know that this could be captured by one term, and that's death panels. And who they see, when they see them, and what is done to them or not done, that individuals in the United States feel that it's their innate right. They see this as a basic human right, and they wouldn't think of this as a commodity. So we should not equate a right with something the government must manage or handle, and we should take responsibility for our rights. So that's why I think we have to view it as our right, continue to view it as our right. When it comes to health care, we're doing a very poor job, actually, of taking care of our rights. In the United States, certainly we are. As a society, in the case of my profession as a physician, we've abdicated far too much to others. We've abdicated to hospitals, to insurance companies, to pharmaceutical companies, to many others. All of these are businesses, and we've abdicated our rights to businesses, and that is never a good thing to do. There's much that we can do that we're not doing, or that we're not doing well. So now the example I know most about is drug cost, and this being, again, we have a right to that drug, but what about its cost? It's emblematic, in my opinion, of the poor job we're doing. And the evidence for that, I think, is crystal clear. We've been railing against the high price of drugs for a decade, Richard, or more. And what's happened during that decade? We've made no impact on the trajectory. In fact, I would argue that the trajectory has escalated rather than reached a plateau. It's actually because we lack a consensus and because we lack resolve. I think nearly everyone agrees drug prices are too high, and in the case of cancer, it's really not delivering on its promise. But the truth is, most people really don't care. You care only when you end up with cancer and with a bill in your hand, or where your doctor tells you you need this and you go to the pharmacy to pick up the pill, and all of a sudden your copay is extremely high. But people should care. And because in the case of cancer, it is having an enormous impact on our success or our lack of success. And I really believe that this is incredibly important and being overlooked. And that's because high drug prices has spawned an epidemic of Me Too drugs. In the United States, there's been, I'll talk about them at the end. There was 2 drugs recently approved in the last year, basically, for the treatment of cancer that are immunotherapies. There's now before the FDA probably more than a dozen drugs that are essentially identical. So we're spending billions of dollars, enrolling thousands of patients, and devoting millions of man-hour and women-hours to basically develop India's Coca-Cola, which I look when I got here. Yours have sugar, and as opposed to the U.S. Coca-Cola, which has high fructose corn syrup. But really, the difference between these two, and I mean this sincerely, that subtle difference, they taste a little different, that's all, is really not too far removed from the differences between many of our Me Too cancer drugs. We really are developing India and American Coca-Cola. And if you think a difference of this magnitude is going to bring a substantive progress in the fight against cancer, you don't have a grasp of how difficult to fight cancer is. And that, I think, is an enormous problem. And we have no one to blame ourselves. And this is why we have to view it as a basic human right. If we think of it as a commodity, I don't think we'll have the resolve to fight for it. We'll just see it as just another government commodity, and it's someone else's problem that it needs to be taken care of by them. So it is a basic human right. But I think once we get past acknowledging that, and once we resolve to fight with passion for our rights, then and only then we have to go ahead and treat it and manage it as a commodity, because that is real life. So I'm just going to give you something that's an opinion, and some might view it simplistic. I think it's straightforward. So I talked to you about these 2 immunotherapies. One is called Keytruda. It's also known as pembrolizumab. And the other one is Opdivo. It's also known as nivolumab, or in the jargon of oncology, pembro and nivo. They're identical. They both target the same thing on cancer cells. To intervene in the same cancer, and the same thing. There's a receptor on T cells, which are the immune cells that are going to destroy foreign objects. It's called the PD-1 receptor, and cancers and other things can make a molecule which is called PD-L1 that comes and binds here and silences T cells. These antibodies bind here, don't let this silencer bind, and the T cell or the immune system can function unopposed and do what it's supposed to. Presumably, cancer basically turns the immune system off. This prevents cancer from turning the immune system off. The 2 drugs are identical. They basically are approved in the same indications in the United States. Pembro is behind Nivo a little bit, but catching up. But if you talk to people who work in the field, they're essentially indistinguishable. And what I say, if I had to go to a desert island tomorrow and I could only take a limited number of drugs, I'd take one or the other. I wouldn't take both, because I would be taking the same thing. The National Cancer Institute, for example, has approved nivolumab already for these 7 indications. There's actually something interesting. Increasingly, not the National Cancer Institute, the FDA, increasingly they're being approved with less and less data. This becomes critical. In patients with non-small cell lung cancer, nivolumab, I circled this wrong. In patients with non-small cell lung cancer, nivolumab was approved in a clinical trial that enrolled only 272 patients. This is trivial when it comes to clinical trials. 135 received the drug and 135 received the controlled therapy. In Hodgkin's lymphoma, 95 patients in a single-arm trial were all that was needed for approval. This is another medicine that I work with, and it's called octreotide. It's a drug that targets something called the somatostatin receptor, and somatostatin is here. It's a small peptide, somatostatin, and octreotide and a recently approved drug are just parts of this that are finely tweet, but not too expertly tweet. Years ago, this used to cost $2,000 for a shot. It's actually used for cancer, although it doesn't have approval for cancer in the United States. It's one of these so-called off-label use. Now it costs $14,000 to $15,000. The price has escalated basically $1,000 a year. The company has done nothing, absolutely nothing to earn that, okay? So another company, a French company, I think, thought, well, we're going to get into this, and they made a compound that is nearly identical. I can tell you that there's probably in the audience, and there's certainly in India, thousands of chemists that are smart enough to make another one of these. So what I'm proposing to you is that actually we're only $1 billion away from affordable cancer drugs. And it's very simple, and I think it'll achieve affordability, and it will achieve progress in cancer. We start by making an Opvita or Keytruda. These are easy to make. There's already more than a dozen before the FDA. We can make one of those. We then conduct a clinical trial, and we know who to conduct it in because the ground has already been broken. And the FDA doesn't need a lot of data, so we don't need to enroll 10,000 patients in clinical trials. We only need to pay for very much less than that. We get an FDA approval. At that point, we've spent very little money, and we can sell that drug for very little money. This has two things that it does. Number one, it provides a drug at much less cost. But number two, to me, it's very important. It totally disincentivizes Me Too drugs. Because any company that is making a Me Too drug because it's $15,000 a month and they want a piece of that pie, now has to reconcile the fact that we might make one and sell it for $2,000. People won't want to do it anymore. As I say, there's some chemists here in India that can make one of these tomorrow, and we'll sell it for $2,000. No one else will come into this field and make that. We can make drugs that have already been proven and can then sell them for far more less. All we do is wait until the drug has been proven by others who have spent all their money, and we have a linear path forward. I don't think this is fantasy. I think this is real, and it doesn't require a lot of money. All of the drugs, all of the targeted therapies that have been approved in the last decade, there's been Me Too drugs that have been developed. In kidney cancer, for example, there's VEGF inhibitors. There's 7 approved by the FDA. There were over 100 that were tested. Some companies just gave up because others beat them to it. This can be done. And we just need to have a collaborative effort to do this and the resolve to do it. In the end, then, we would then be arguing for a basic commodity or a human right that actually would be affordable. And we'll sell it for $2,000 in the United States, and we'll practically give it away in developing countries. But we'll be able to do this because it didn't cost a lot to develop. I'm sure there's a lot of pharmaceutical company people that are thinking, oh, you're just so naive. Actually, I'm not naive. I've been here and I see how it happens. And yes, there's a lot of things that need to happen, but all of this can be done. So I think it's something that we need to think about. And maybe then in the future, we won't have Me Too drugs. We'll have companies really devoting their energies, their money, their efforts to novel drugs. And then not only will we have affordable drugs, but we'll have better drugs for cancer and better outcomes. So again, I think that David and I are really on the same page. And I don't think anybody won or lost this debate. Our goal was to just bring it for discussion. And in the end, it is a human right, but you accept that, you also have to recognize it's a commodity. So I think the answer is that it's both a basic human right or a need and a commodity. So thank you very much.
Well, thank you, Dr. Fojo. That was really thought-provoking. What we're seeing here is that while we have scientific data, we have to be able to bring this into the real-world context of management and making decisions and not using the evidence in an appropriate way. And this brings us to our debate. So I'm wondering if we could have the slide up that has the text for today. Do we have that? So the specific assignment is healthcare a commodity? And we wanted to make sure that we had clarified what the topic of the debate is, and we sent the text this morning to be added. Oh dear. If we don't have that, actually, Dr. Johnson, Mr. Johnson, do you have the text as you wrote it? I've got it in my phone here. Hold on for a second. Excellent. So thank you very much. The question is healthcare a commodity that can be bought and sold efficiently in the marketplace? And David Johnson will be taking that position. Or is healthcare a human right that operates outside market forces and requires government support? And Dr. Fojo will be addressing this. Now, we in the United States, because of our recent election, have become sensitized to irregularities that in the way that things go. And I just need to point something out that has come to my attention. And Mr. Johnson actually has been assigned this topic, and what he went and did was wrote this 400-page book about this very topic. And I would consider that a serious irregularity, if not serious over-preparation for a debate. So, David, if you could come up and present your position that a commodity can be bought and sold efficiently in the marketplace. Actually, I don't know the answer to that question. Are we having voting or... And we will have voting as a show of hands. Actually, should we do a before and after? Okay, so if we're going to do a before and after, I'd like everyone on the front to remain neutral, keep your hands down. Everyone in the audience, I'd like you to raise your hand, and if you say that healthcare is a commodity, yes. I think you've got a challenge, David. And how many think it's a right? Oh my. Well, here we go. It's up to you now.
Well, namaste. Well, one thing I think we can all agree on, even though this is a debate, is I'm wearing a vest from Fab India, and I think it makes me look pretty sharp. How many agree with that? So as Ben was saying, we struggled with the definition of the debate. There's an old joke that says United Kingdom and the United States are two countries separated by a common language. And commodity is a word that has a lot of different definitions. And since both India and the United States are colonies of Great Britain, I think that's continuing. But this debate that we're talking about has occurred before. Right arrow button. Okay. Oh, there it is. Okay, great. So this debate has occurred before. And really, when we're talking about health care, and we saw evidence of it yesterday, the debate about health care policy really is what's the role of government? And different countries come out differently on this. So France yesterday in the presentation that we listened to is really socialistic. Government owns hospitals, doctors work for the government, government pays for everything. So it's a market socialist system. India, on the other hand, was almost a perfect example of a cash payment system, kind of pay as you go, and then every flavor in between. So, as I said, this argument of free market capitalism versus market socialism has been going on for a long time. And here's an admission: I'm a little bit addicted to the Great Courses program. And for those of you who don't know what that is, those are lectures by university physicians, and I listen to them in the car. And several years ago, I was driving through the great state of Indiana, the home of our new Vice President, Mike Pence. And I was listening to a lecture about the the Austrian School of Economics. And right after World War II, there was a very vigorous debate about whether market socialism or planned economy could outperform a free market capitalist economy. Fast forward today, and I think everybody would say free market capitalism outperforms market socialism. India is a textbook case in that. But at the time, Europe was in ruins. Memory of the Great Depression was still fresh in everyone's mind. Many have argued that both fascism and communism were manifestations of the extremes of unbridled capitalism. So it was a really vigorous debate. Couldn't governments do better? And a proponent of free market capitalism, Friedrich Hayek, kind of stepped into this debate. And he used the price of tin to make his point. So in free market capitalism, price contains meaningful information, so much so for Hayek that you almost didn't need to know anything else, that the price transmitted an enormous signal to the marketplace and influenced behaviors. Marginal users of tin found substitutes, essential users adjusted. Ultimately, the prices correlated, some rose prices, and the market got back to normal. So what happens in a market socialist system? You need a large number of technocrats to identify what are all the uses of tin. Then they have to assign priorities to each of those uses. They have to set prices for each of those based on the priorities. And then they have to have a market enforcement mechanism to make sure that everyone's obeying what the prices are. And before long, it gets really complicated. Well, I was driving along and I said, holy cow, that's Medicare in the United States. We have an army of people in Baltimore that figure out what to pay for health care. They have these very complex formularies. And before long, it gets really complicated. And as I was listening to the end of this tape, I was driving into Indianapolis, capital of the great state of Indiana, who was at that moment building 4 cardiac surgery centers at a time where the incidence of cardiac surgery was actually declining. So the incentives in the system were not sending the signals out properly. So part of what's happened in America over at least 50 years has been ever more gross distortion of the supplies we have to deliver Medicare and the needs of society. Okay. Ben, I know that there's something here I can...
Right. This one.
This one right here? Oh, boy.
Try again. That one.
Okay.
There you go. It's the left and the right.
Okay. So I sat down and I wrote a 400-page book, as Ben was saying. And this chart appears on page 267 or whatever. And I actually was trying to figure out how to look at the totality of activity that occurs within healthcare. So on the x-axis, you see care duration from episodic to ongoing. And on the y-axis, care uncertainty, low to high. So if you just do a standard, consultant 2x2 matrix, you can break this up into 4 types of care. And if it only happens once, and you have a high degree of certainty that the outcome is going to be positive, definition of outcome shifts, not am I going to have a good outcome, it's price, customer convenience, customer experience. That by definition is a retail event. It's a high volume, low margin business. As you go up, specialty care, episodic and high uncertainty, that would be something like a heart transplant. You go up to the upper right corner, those are the really solution shop, complex cases, comorbidities, and so on. Very, very tough. And then you come down and non-acute chronic care. Well, if you look at these are fundamentally 4 different businesses, and yet health systems tend to smash them all together. They have different supply chains, different customers, different efficiencies, and so on. And what is starting to happen now in the United States as we shift into more of a market-oriented system is different businesses are choosing to compete in each of these areas based on price and so on. The other thing that's happening is healthcare is shifting down. So something like a knee replacement used to be the very definition of specialty care, and if it's not already, it soon will be very routine. They're done in high volume with high certainty and so on. So the more care that's routine and subject to retail pricing, almost by definition, is a commodity. And the way that companies then differentiate themselves is based on their brand and customer experience. So if this is the new game, that outcomes really matter, here are the rules. I'm only going to focus on one of these, but quality is job one. It's remarkable in how many healthcare systems quality is not the most important thing. It's usually revenue generation. That we need to look at the entire care episode, not the individual treatment codes, again, because we tend to pay based on treatment codes, not on outcomes. It skews behavior, skews results. Prices increasingly matter. Data is as data does. You know, everybody thinks big data is a solution, but you know what? If you don't get the little data right, the big data is going to be even more screwed up. We actually just saw that in the mammography case study. And then finally, it's the customer, stupid. Healthcare is a funny business. We execute transactions without customers. Patients go to doctors, doctors prescribe behavior, and somebody else pays for it. We lose the essential link that is the relationship between the buyer and the seller. Einstein had a bunch of great things to say, as you know, but one of them was you have to learn the new game's rules and play them better than anybody else. So if these are the new game's rules, you have to ask yourself, how many organizations are really living up to these 5 standards? But I guarantee you, going forward, those that do are going to be the ones that differentiate and win. Oh, man. Oh, there we go. It's just slow. So I said I was going to talk about data. And the way to look at it is data is the middle layer between value-based care, doing the right thing, right price, right place, and then customer engagement. It's not enough to do the base. You also have to engage customers, and there's data that flows back and forth. But let me just talk about, because I know I'm getting near the end of my time here, let me just talk about one example of interfacing. So last night, we were going back to the hotel, and it's hard to get if you don't live here, it's hard to figure out how to get a taxi. Well, I just pulled out my phone and did Uber. It cost me $2.12 to go from here to the hotel. So that's an interfacing company, that thin layer between the suppliers, the taxis, where the costs are, and the customers like me, where the money is. So this is a friend of mine who's creating a company called Best in Class Care, and it's have it your way. And you can pick a procedure, you can tell where you're departing from, you give your dates of travel, and it's easy, it's transparent, and next thing you know, okay, yeah, thought somebody else would do it. You can tell, you can choose your procedure and the date. It includes all travel costs and in some cases, this is incredible. If your insurance company has a bundled price, they'll give you savings. Wow. This is today. This is bundling Expedia with medical tourism. So, you know, it's all going to be on your smartphone. So next one. So at the end of the day, when making the case on why healthcare is a commodity and it requires market forces, we know that when governments allocate resources, they often get it wrong, like they did in Indianapolis. Marketplace is essentially better at doing it. We saw examples of that in some of the model discussions yesterday with companies like the Aravind Eye Clinic or Eye Care Company. So at the end of the day, what really matters, final slide. Oh, here it is. Okay. Outcomes matter, customers count, and value rules. Hopefully I persuaded at least a few people in the audience. Thank you.
So I'd like to ask one question of each of our debaters, and then we'll revote. David, you made a very cogent argument for this being a commodity, and if I want to buy a new widescreen television, I go to the store, I pick up my television, I might be talked into one thing or another, but I know what I'm going. Or if I decide that I want to get these bags under my eyes fixed and get a blepharoplasty, I can go to my plastic surgeon, I know what I'm buying. But if I go in with abdominal pain to the hospital, I don't know exactly what it is I need. I'm going there to find out. So isn't that a fundamental violation of this customer idea? The customer actually needs to know what it is that they're buying. What are your thoughts on that? If you could turn on your microphone.
That I know how to do. Well, that kind of gets at your question gets at the essence of this. And by the way, I really liked how Dr. Bodway began the conference, where he said that healthcare is a human right and it's also a business. I guess the way, Ben, I'd answer your question is 80 to 90% of healthcare actually is pretty straightforward and probably subject to true market forces. The average MRI in the city of Chicago, where I live, costs $2,600. There's a company that's come down from Wisconsin that's now running ads on the sides of buses saying an MRI doesn't have to cost an arm and a leg, and the cure for the $2,600 MRI. And basically, they will do an MRI with a reading from the Cleveland Clinic for $600 or less. So that's a clear example of a product that you can buy, you know what it costs, and you can make some judgment. And we could go on and on with the list of things. The variation in pricing in U.S. healthcare is remarkably different. But to your point, where you don't know, that's what lends itself, I think, to population health-based pricing, capitation-based pricing, so that you develop the capabilities to manage the health of large groups of people. So the biggest deficiency in the United States and in many systems around the world is we don't do a terribly good job of managing care of large populations. We tend to treat the byproducts of illness. We aren't good at prevention. We aren't good at chronic disease management. It drives me crazy personally in the United States that there's plenty of money in the system to amputate a foot, but there's no money in the system to manage the chronic disease to prevent the amputation in the first place. So, we're kind of having a false debate here, right? I mean, everybody believes healthcare is a basic human right. I think the real question is, how do we organize societal resources to perform the healthcare function in the most efficient way that benefits patients? And everything that Tito talked to you about this drug was outcomes-based. It wanted transparency on data and pricing. And ultimately, it has to be good for patients. And it's remarkable how much of the time we don't have any of those things in healthcare. So I'll just finish my comment by saying, not only do you want healthcare to be a commodity, you want it to be transparent, you want it to be customer friendly, you want to know what you're getting. We need it to be a commodity because with all of the opaque pricing and lack of data transparency and shifting away from focusing on outcomes and instead focusing on process, we're spending enormous amounts of sums of money, and we're not keeping our populations healthy and productive. So one of the things I sometimes do when I'm talking to audiences in the U.S., I say, how many believe we need to spend more than 18% of our economy to provide superior healthcare services to everybody in the country? We heard the next big country, which is France, they're at 11 or 12%. And I've never had one person tell me we need to spend more than 18%. So fundamentally, our issue isn't how much we're paying. There's more than enough money in the system. It's what we're choosing to pay for. It's a distribution issue, not a funding issue. And that gets to the heart of what we're talking about today.
And Tito, I'd like to ask you, you made a very cogent argument that this is a right. Healthcare should be a right. Yesterday, Richard Sullivan and I were talking, and there were so many presentations yesterday about universal health care. And I don't know if it's widely recognized, but actually cancer treatment is generally not included in universal health care packages in many countries, if perhaps not most countries in the world. So actually, when we assert that it's a right, is that in fact a fraudulent assertion that it's a right? Because we do not take responsibility and deliver on that which we say is a right. What are your thoughts?
I mean, so clearly, yeah. How can I disagree with that? It's a right, and it's indeed not covered. Or, even in the United States, patients have to make choices as to what they're going to do. Even if they have coverage, they still have to make choices. And it's not only about cost, but also about so many other factors that even insurance then can't capture. So I'm not quite sure that I can add anything. You said it all in your question, that it's
Then let's go to a vote, and as based upon what these gentlemen have said, there are going to be three options. Option number one is that healthcare is a commodity. Option number two is healthcare is a right. Option number three is it's both. So everyone who thinks that it is a commodity, raise your hand, please. I see no hands. Anyone who thinks that it's purely a healthcare is a right? Quite a few. And how many think that it's both? Well, David, you did a really good job with this tough audience. Thank you very much.